The Virtual Curbside is a production of the Utah chapter of the American Academy of Pediatrics, the Utah AAP, working together to improve children's lives through education, advocacy, and networking. Hi, this is Paul Wirkus from the Utah AAP. Welcome to this week's edition of the Virtual Curbside, where we bring pediatric providers together with subspecialists to get smarter about all things pediatric and better acquainted as a community of caregivers. The Virtual Curbside is brought to you in part by a generous grant from Primary Children's Hospital. Primary Children's Hospital, the child first and always. Welcome back to the Virtual Curbside. We are very fortunate that Dedee Caplin agreed to come back. I'm sure that the ordeal of the first 3 weeks was ordeal enough, but you're so kind to come back and answer our questions. Welcome back.
Thank you. I'm actually excited. This is the fun part.
We want to do a two-part thing this week because as we were talking offline after the last recording, I was asking about basics of CBT, and you said, here's a good idea. If we don't get too many questions, why don't we talk about some basics of CBT, because you've done this for providers before. And you said you would do that, and it's so kind of you.
Well, I'm excited to do it because there aren't enough providers, and it's a relatively easy therapy to implement if you can pull it off in your office.
All right. Let's start with a question that we're going to use as a bridge to this. This is from Sean Park, who said, thanks for a great podcast. Can't wait to hear the rest of the series. My question has to do with Dr. Caplin's focus in integrating mental and behavioral health care with medical care. Where can pediatricians go to learn what she is working on and how to do that better? Is her program developing practice guidelines or maybe a textbook or something along those lines?
So I'm definitely not writing a textbook. That just sounds really hard. And I'm not sure I can pull it off. Our hospital system has some practice guidelines for working with kids with disorders that cause pain and functional disability. And we're implementing those hospital-wide. And those are certainly things we are willing and more than happy to share with other hospital systems or with other providers. They usually involve focus on communication as the intervention and how do you communicate about disorders in a way that guides you to the right kinds of treatments. A lot of times what we hear from pediatricians is it's really hard to sell behavioral health. And you don't really need to sell behavioral health so much as help people understand why you want them to go to behavioral health. And so that communication piece becomes really important. And we definitely have a lot of those guidelines. If you want specifics on how to start nerve reprocessing, how to start cognitive behavioral therapy, how to start, exposures and reducing catastrophizing and magnification and those kinds of things in your office, I think today's session will help with that because we can talk about some of the very simple things you can do to create that space where change can happen.
Excellent. And can we link to any of those things in the show notes? We could link at least to your slide set that is the basis for what we're talking about today. Well, so we wanted to spend the rest of the time today talking about CBT in the office setting and some basics that we can incorporate in the way we talk to patients. So before we dive into that, have you developed any disclosures that you'd like to share?
No, still nobody has stepped up to commercialize what I'm doing.
Okay, so if anyone out there would like to help Dedee find conflicts, let's because you're good at conflict. That's what you're trained to do. Let's talk about CBT. So what kinds of problems might lend themselves to this approach in the office?
So cognitive behavioral therapy in general was first developed around things like anxiety and depression. It's got a very solid evidence base at behavior change that leads to then changes in emotional reactivity, cognitions, and we've learned that there are ways to apply that to a variety of problems. So now there are branches of CBT. There's trauma-focused CBT, there's insomnia CBT, and there's pain CBT, which is the management of pain using cognitive and behavioral principles. And I think that's primarily what we're talking about today. But again, when you think about CBT, it's a fairly broad representation of an evidence-based therapy that uses a combination of cognitions and behaviors to then change something that's going on in the body.
And it's interesting because when we're dealing with things that have a lot of pain issues, I think that our training is generally to, first of all, put it in a box so that we can name this thing, and then to direct people to therapies, but there's probably great power also in recognizing that this all exists in an environment somehow, right? That the pain issues that you have may lead to loss of function, that there may be some social and environmental impacts, and that the person is not a machine, and so their own psychology has an impact on all this. Is that a fair foundation to build on?
Yeah, I mean, not only is it fair, I think it's representative of how people experience pain. Like if you have a pain is a normal part of a human experience, right? And so everybody experiences it, everybody knows what it is, but no one can say that what they experience is what someone else's experience is. And so I think there's a personalization of pain. And so when we talk about illness experience, when we talk about a pain experience, what we're really looking at is what are the multiple impacts of pain on a person's functioning, on a person's life. Loss of function really means, are you doing less? Are you not doing the things you're supposed to be doing or want to be doing, right? Social and environmental, are your parents suddenly changing what they're doing or how they're doing? What is the family system doing in response to the pain? School, activities, things like that can get impacted pretty quickly. And then I think from a psychological aspect, it's this idea of understanding the role that bidirectional stress has on pain itself. I think that a lot of times families come to me therapeutically and they say, I'm seeing a psychologist because my pain is on my head. And technically they're correct because pain is a nervous system response. So of course it's in your head because your brain is processing it. But I think what they're trying to say is they think it's psychological. And that's not necessarily the case. Pain is a much more complex experience than that.
So let's lay the foundation then for cognitive behavioral therapy. Let's talk about a couple of terms that belong to the discipline. We're talking about pain cognitions. What's catastrophizing?
Catastrophizing is the coolest construct in the universe. Catastrophizing can occur both with patients and with parents. And catastrophizing is the process of taking any kind of nervous system signal and amplifying it. You're making it bigger through making it a more serious thing. So your thoughts are saying, it hurts, it hurts, it hurts. It must be bad, bad, bad. It's going, going, going. Oh my gosh, this is getting worse, worse, worse. That is what catastrophizing is. The human brain naturally does it. And if all we learn how to do is control that, we've actually helped create a process of change in the pain response.
How is that different from magnification?
So magnification is actually just the pain escalation piece of it. So catastrophizing is kind of the thinking part, and magnification is kind of the physical part and the representation in your body, but they work hand in hand. Catastrophizing is a form of magnification.
Gotcha. Okay. And then how do biases play into that?
So our biases are really created by our prior experiences with pain. And when you think about a child's experiences with pain, you're talking not just about their pain in the moment, but you're talking about, like, historically, what is the family's relationship with pain? How does the family system respond to pain? How does the patient respond to pain? Is this a kid that every time they were full had a bellyache, and every time they had to poo, they had a bellyache, and every time they were stressed, they had a bellyache? Or is this a kid who's never really experienced pain before and doesn't have a construct or a system to represent it? I think the other piece about biases is there's a learned helplessness, that pain is something that happens to me. And if it's coming into me, I have absolutely no power to change it. And so sometimes what we're seeing is that kind of helpless feeling that there's nothing I can do. And other times we're trying to work against kind of prior cognitions, prior thoughts, prior beliefs about pain in the family system.
And it seems like persuading people that they're not helpless is sort of the first step to say there are some things we can do.
You make it sound really easy.
I'm not saying it's going to be.
However, convincing someone that they're not helpless is actually a really hard part of the job.
Well, I was asking you earlier.
I think you're absolutely right. Like, I can't tell you the number of times I've had families say things like, you don't know what it's like to be me. And I don't. And nor should any of us suggest to patients that we know what it's like to be them. But just because we don't know what it's like doesn't mean we can't do something to help. And it doesn't mean that we can't teach you ways to help yourself. And I think chipping away at that and chiseling away at that is certainly the easiest way to kind of start to attack that learned helplessness, to kind of help people recognize that there are things you can do. I usually start with some very simple behavioral interventions that will help people get an immediate response, because if you get an immediate response, all of a sudden the light bulb goes off and you're like, oh, I'm not as helpless as I thought I was. It doesn't mean you're not always helpless, or that there's not going to be situations where you're still not helpless, but it certainly takes kind of the edge off of it. And you can no longer, paint yourself in the box of there's nothing I can do. And so I think my first goal therapeutically is always to give people something they can do to respond to pain.
Well, and if they do buy into that, it definitely imparts some hope into the equation, because a lot of times when we're dealing with chronic pain, there's this kind of hopelessness that, wait, I'm going to feel bad forever.
Right. No, the forever feeling like I can't imagine personally what that is like, because I've never experienced it, right? To be in a position that you think it's going to happen forever, and to be a kid in that position is just devastating. What I do think is that when someone says that to me, my first response always is, forever? Really? Forever? Like, you think you're going to be 85 and still right where you're at right now? Are you sure that's going to be the case? Because most people don't actually believe that, and they just need someone to kind of push back against that to get them to start moving in a different direction.
Well, so give me some ideas. What are some simple behavioral interventions that where would you start?
Yeah, so I think where I start first is educating both parents and patients on what pain is. So everybody has heard of, or at least understood, that there is this biopsychosocial model of pain. If you Google it and hit images, you will come up with 35 graphics that can actually help people understand that pain is a much more complex construct than simply a nerve firing to the brain. There's a lot of things that are going to feed into it. There's a lot of things that are going to pay attention to it. That actually gives you credibility to start to discuss the idea of distress, worry, catastrophizing environment, and those impacts on pain. If you just talk about pain as a simple like stimulus response, get rid of the stimulus and the response will go away, you're a little bit stuck. But if you start to kind of say, hey, there's influences of attention, which is why when you're doing a pleasant activity, you hurt less than when you're doing a not pleasant activity. There is an impact of sleep, which is why when you have a good night of sleep, you can actually tolerate your pain better the next day. And when you have a bad night of sleep, it's much, much worse. Right? So there's a lot of ways that you can kind of use simple examples to help people understand the nuances of that biopsychosocial pain experience. But I think it's really, really important to educate families about pain catastrophizing, about their role in controlling the environment. So one of the very first things I do to help parents in that process is I say, okay, you are allowed to talk about pain as long as you don't say hurt or pain or discomfort or feel. And as long as you don't say any of those words, you can talk about pain as much as you want.
Yeah. So what do you do?
So they look at me and they say, well, how does that work? And I say, well, I'm not going to tell you not to check in with your child, but if you check in, say, are you comfortable? Is there anything I can do to help you be more comfortable? You look uncomfortable. Let's find a way to help you feel a little bit better. So then all of a sudden, you're really starting to focus your attention, your energy on movement towards a response versus sitting in that feeling space. And then with patients, I'm always talking about, I want you to follow every feeling with what you're going to do. I feel this, so I'm going to do this. I feel this, so I'm going to do this. Because that feeling of pain, if we sit in it, magnifies, catastrophizes, gets bigger and bigger and bigger, and then it really kind of feeds that helplessness cycle. And so really the idea is get out of that as quickly as you can. Feel, do, feel, do, feel, do is kind of that mantra that we want kids to be paying attention to.
How do you help them come up with an alternate response?
So the alternate response is usually like that do part, right? I feel, therefore I'm going to do something. Yeah. There are very specific things that research tells us are really, really good simple pain management techniques. And those very simple pain management techniques usually involve something called counterstimulation or relaxation. So relaxation is a response everybody thinks they know, but a lot of people don't really think much about. But if I say to you, I want you to relax, you might think, umbrella, drink, splitting on a pool somewhere. But what really we're talking about is I want your blood to flow evenly. I want your heart rate to be even and optimized. I want your muscles to be warm and relaxed. And if we have that response, your pain is going to drop. And so teaching people simply why you want them to do relaxation becomes a skill set that anybody can do that creates a huge pain management response for kids. Counterstimulation is simply blocking one signal with another. So you have a pain signal that's firing up to the brain, and you say to the brain, I am going to give you a simple, strong, and pleasant signal that's going to block that pain signal for a minute. Ice pack on an injury is an easy example of that. If you put the ice on the injury, what do you notice? It's cold. You don't notice the pain. You don't notice anything else. You notice the cold. And that cold sensation is giving your brain a break from the pain, right? So it really just starts to pull you away. But if you start to target that counterstimulation, every time I notice an increase in pain, I'm going to do something sensory that's strong, simple, and pleasant. I'm now blocking the pain on a regular basis, and I'm reprocessing those nerves to really try to get that pain response to drop down.
Going back to the relaxation part, how do you tell people to create that relaxed self?
So you don't say relax. Because it turns out nobody relaxes when we tell them relax. And you don't say take a deep breath, because nobody can take a deep breath when we tell them to.
You don't shout relax either.
Right? But oftentimes I use like apps, right? So if you are in a busy practice and you have no time to teach people this, oh my gosh, there's the Calm app, there's like Insight Timer, there's what else? I'm trying to think. Now I'm blocking it completely, but there's one called Smiling Mind, which is a mindfulness-based relaxation. There are plenty of options and opportunities out there. The idea of relaxation, though, is it has to be personalized. So I would never kind of say to anybody, this is the thing you have to do. But what I would say to somebody is, if you are in that place where your body feels like jello, your muscles are so relaxed, your brain doesn't feel like it can hold the thought, what are you doing when you're doing that? And how do we recreate that? Because that's what we're looking for. So sometimes it's something as simple as a hot pack or a cold pack on the back of the neck. Sometimes it's a mindfulness-based relaxation. Sometimes it's listening to music. Sometimes it's paced breathing, which you can train yourself to do. And I think all of those things are things that the average pediatrician can easily learn how to do or easily learn how to tap into to be able to teach people how to do.
Let's talk about the SMART goals again, because you talked about those before. Do you do those almost universally?
So I check into them almost universally. I have a lot of patients who function pretty well and maybe are lax on one or another of their SMART goals. And just kind of for recollection, kind of SMART is like sleep, meals and hydration, exercise, relaxation and stress management, and triggers and barriers. Right. And so you kind of create this idea behind how do we use healthy lifestyle modifications to become actually pain management techniques. I can tell you every patient I've ever met has heard of all of these lifestyle modifications. 80% of them have never been told why they need to do them. And I don't know about you, but I work with a lot of teenagers who, if you don't tell them why you want them to do something and don't sell them on the why, they will not do any of it. And they think you're an idiot and you're just kind of patting them on the head and sending them on their way. And so they feel invalidated. So the time I spend on SMART goals is not you need to get 8 to 10 hours of sleep. It's, hey, there's 5 stages of sleep. And as you go through your stages of sleep, you spend more and more and more time in REM sleep. That REM sleep is what's helping you with pain management. So I need you to sleep 8 hours so that you're getting 40 minutes of REM sleep per cycle, not 5 minutes of REM sleep per cycle, right? So I talk to patients a lot about those details and why I want them to do the things they're doing. And I think that really helps us make a plan for those SMART goals and why it's important to do it, but it also sells them on what they need to do and what the impact is going to be.
That's very helpful. It's not just like a set of prerequisites that you need to take this class to do.
No, how many people floss?
I do.
Right? But do you do it because you know why? Or do you do it because your dentist said, hey, you need to floss, right? Like, you need to do this is probably the worst thing you can say.
Yeah, right. Because then people just feel bossed around.
Yeah.
Helpless. and they start to catastrophize. Let's talk about what the impact then is of pain on thoughts, emotions, and behavior, and then how you intervene, because those are all different.
Yeah. So I think, the thinking part of pain is big. Like it is really, really important. I can't express enough how important your thinking is in determining what you choose to do. You can talk yourself into things, you can talk yourself out of things. And when you're in pain and your brain is over focused on the pain, if we can't pull you off of that, it's going to be really hard for you to decide to do something different than what you always do. And so it's the elephant in the room. It's important to talk about what are the thoughts that you have when you're in pain and how do you manage those thoughts. If you know that someone's thoughts are interfering, getting in the way, they are like completely biased, they're defensive, they're having a hard time, you probably do want to refer them to a therapist who understands pain management, because they're going to have to really work on that. And sometimes that's like a chisel approach, not a sledgehammer approach. So it really takes some time. When it comes to emotions, oftentimes what we're really talking about is distress tolerance. How do I tolerate my pain? I have a patient who has a ring, and on the ring, on the outside of the ring, it says, "I'm comfortable." And on the inside of the ring, it says being uncomfortable. And that is how she got to college, is she needed to remind herself that it is okay to be uncomfortable, because I am comfortable with being uncomfortable. I have a way of managing it. It's not going to increase my anxiety. It's not going to increase my distress, and I'm not helpless. And I think, to me, that's where the emotional piece comes in. I think oftentimes we're talking about anxiety about doing things, but that kind of stuff just takes practice. The real distress tolerance is learning that it's okay to be uncomfortable. It's okay to have pain, as long as you have something to do to be helpful.
So basically, all of this assumes that this is something that we're teaching someone to live with, as opposed to this will make everything butterflies and rainbows.
Yeah, butterflies and rainbows are a really hard construct.
Yeah.
But I understand what you're saying. So I think you make a really good point. I think a lot of people think it hurts, something's wrong. As soon as we fix the something that's wrong, the pain goes away. That's how our brains are reinforced and designed to kind of think about pain. Right. But chronic pain is the problem. So it hurts is the problem, not it hurts, so I got to fix the thing. This is the problem. And so with chronic pain, we really have to learn how to manage it, how to reduce it, how to function through it, and then how to reprocess those nerves so those nerves stop firing. And that is why cognitive behavioral therapy for chronic pain is really like a standard of care, or should be a standard of care. It really takes us to that place where we improve self-monitoring, reduce functional disability, change our pain cognitions, change our pain behaviors, reduce distress tolerance, and as a result, we're a functional human who sometimes feels uncomfortable, rather than somebody who is completely determined by their pain.
I guess to my simplistic mind, it's sort of learning the difference between if an analogous signal in my brain is hunger, that I'm hungry, the solution to that is I eat, and then that fixes everything.
Mm-hmm.
That pain is, in this instance, something that we learn to reformulate.
Well, and we talked about it earlier as like a software problem, not a hardware problem, right? If it's a software problem, like there isn't a simple fix, right? There's how do we rewire the system so that it works kind of around that, or it works through that? And I think that is one of the things that I have recognized really helps determine kind of the trajectory of change for a lot of my patients, is the patients who recognize I am in a process of change versus I am looking for that magic bullet that stops this.
All right. And I think this is where it's going to be vital that people can also look back at some diagrams. And so we'll link your slide set. Our squadron of linkologists will make sure your slide set is available to look at.
Yeah, I would love that, because I feel like it's relatively self-explanatory. This is something that I certainly do all the time. And so I recognize that for me, there's just this ease with I can kind of move from one thing to another and talk about it. But what I can tell you is, through 25 years of training residents, training students, training graduate students and psychologists, anybody can do this with enough practice. Like, you just have to practice saying it, understanding it, and believing in it yourself. Like,
Sure.
if you don't think pain is real, you are never going to be able to sell this model to somebody else.
Right. Right. And I think that if you're not sold on the fact that pain is real and this is a very valid approach to helping people do pain.
Mm-hmm. Mm-hmm. It's fascinating to me that, we end up in this situation where it has to be an either or. And I think getting out of that idea that there either is a physical representation for pain or it's psychological is really kind of the first step to moving to this place where we can actually treat it. Like, if you really think that there's just this two silos and that's the way it is, I think it's just going to be really hard for you to ever feel effective in treating kids with pain.
And this is not throwing in the towel. This is not saying, well, I don't know what to do, so let's try this instead. This is really something that it sounds to me like exists in a parallel track with everything else we're doing.
The evidence base is solid. Like, I am very confident in the evidence base. And sometimes it requires that as a clinician, we are confident for our patients because they're not confident for themselves. They're not in a place where they feel like they've got the handle on it. And so for us carrying them through that, like, I know this is really hard for you right now, but I have a lot of confidence in this, and I'm going to help you through this process, is one of the best interventions you can provide for a family.
So let's say I'm treating a patient who has pain issues. How would you structure that visit?
I think the first thing I would do is start with a review of their functioning and really create a space for them to tell their story. Because one of the things that we have recognized in the literature, even clinically, is dismissiveness and feeling invalidated is probably the one thing that escalates care seeking and escalates pain magnification. And so really, like, spend a few minutes and just listen to their pain story, because it is different from everybody else's and it is theirs. I think then what I would really do is kind of set an agenda and help them prioritize what is it that they want to get out of treatment. When they say, I want to be pain-free, I want to not have pain, I think that's an okay long-term goal. I think in the short term, what you want to say is, that's a good long-term goal. In the short term, what is something you want to be doing that you're currently not able to do? And kind of hone them back in. I think then what you really want to do is talk about pain is a construct in the brain. So it's one of those things that's getting attacked by all sorts of things. Our thoughts interfere with it, our emotions interfere with it, our behavior interferes with it, our environment interferes with it. Let's talk a little bit about those things that you know are interfering with your pain, either making it better or making it worse. And if all you do is get a really good structure of what they're functioning and what's interfering with, you're actually, as a clinician, going to find targets that you can then kind of say, oh my gosh, this is the piece we can work on right now. Don't try and tackle the whole thing. Just take that one piece that you know you can work on.
And then help them define that.
Mm-hmm.
Okay.
The one thing that I can tell you, the literature is pretty interesting on visit frequency. So weirdly enough, patients who feel dismissed tend to have higher healthcare costs, more emergency room visits, more what we call doctor shopping, where they're trying to find somebody who's helping them understand and validate kind of their experience. If you, as a clinician, literally listen to a patient, talk about something that you can do, and agree to see them on a regular basis, you can prevent a lot of that escalation. And you can actually be helpful because now they have a partner in their care instead of just another person who heard their story and is helping them move on. And I think one of the things that I notice is the more uncomfortable we are with pain, the less likely we are to do that for families, but it's actually making the situation worse, not better. And so really kind of pulling in on what are my biases as a clinician is probably a really good exercise before working with any patient in pain.
That's interesting. When should I say, yeah, this is not going to work and you should probably see a therapist instead?
So I think it's related to function. So at Primary Children's Hospital, we have our PAUSE program, and it's for kids with pain, other symptoms of dysautonomia, other symptoms that interfere with functioning. And the purpose of that program is to actually help kids create a plan for learning how to get back to function. I think as a psychologist, the kids who don't go to school, the kids who can't function, the kids who can't get to sleep, the kids who can't eat, if something is significant enough that it is kind of just like dug in, we're getting weight loss, we are, missing 30 days of school, we are, all of those things, I think that's a really important time to say, hey, you know what? I am still going to be a big part of your team. I'm going to bring other people into the team. And these are the people that I'm going to bring in. If the problem is physical functioning, I can't walk, I can't move, I can't sleep at night, OT/PT are going to be your kind of go-to people, right? If it's that pain cognition thing, helplessness just keeps me in bed, I can't even get out of bed, I can't get dressed every day, grab a psychologist. If it's more than one system, think about a more specialized program for kids with chronic pain, like the PAWS program or programs in other places.
How much time do you think it takes to have a quality visit?
So I think that patients will take as much time as you have. So you have to be really thoughtful about structuring your visit and kind of like frame the visit, right? I can review where you're at with functioning. I'm going to talk to you about what we talked about last time. I'm going to set an agenda. Recognize that you are working with this piece of like this tiny piece of a very large puzzle, and kind of saying, if you have things that we need to talk about outside of this visit, we need to think about, do we need to have another visit? Do we need to move on? But I would kind of structure it within a 30 to 40 minute visit if you're really doing a solid functional analysis with a patient. I think if you're having a 30 to 40 minute visit with that patient every week and you're not doing something therapeutic, then you probably need to pull somebody else in.
That's very helpful. Any other thoughts about what we ought to be thinking and doing here?
I think that you want to think about patients who don't have motivation. So patients who have either adopted that illness role and are getting some secondary gain out of it. We definitely see those patients and families. Those patients probably would indicate a therapy referral. Anybody who has comorbid psychiatric conditions, anxiety, depression, psychosis, things like that, you're probably going to want to get your team larger and include behavioral health quickly. If you are in a practice where you just don't have enough time to do these things, it's okay to ask for help, but don't write the patient off. Don't send them to me and assume I'm going to take care of it without you, right? Communicate, collaborate, get those relationships going, because I think those can be really helpful. I think overall, with all of your patients, remind yourself that you are part of their team and they are part of your team. It's not you telling them what to do and them either doing it or not. I also think that increasing anything, like if you are working on sleep, if you are working on activity, if you are working on being able to tolerate school, if you're working on pain management, I really want to stress, you want to make it small and achievable so that people are getting minor successes. Because if we throw the kitchen sink at a kiddo, they go home and they have remembered nothing that we've told them. And so really kind of saying, what is that one thing that you're going to do when you leave here? What is that one thing that you're going to work on between now and when I see you again? What is that one thing I'm going to ask you about next time? What is that one thing you agreed to do? Is to make sure that they're really bought into, this is where I'm at.
And so that they're in a position next time where you can praise them for having done hard work.
Yeah, or problem solve with them because it was harder than they thought it was going to be.
Yeah. All right, Dedee. I still don't feel like I'm going to be very good at this, but I'm going to work on it.
You know what? You'll be fantastic if you practice enough. Just saying.
I'll keep practicing. That's very, very helpful. I hope we can talk again sometime.
I would love that.
Thanks for coming, and let's plan to talk again in the not too distant future.
Oh my gosh, thank you so much.
All right, and everyone, tell your friends and relatives to listen to the Virtual Curbside. Thanks for joining us. We look forward to getting together again next time. The Virtual Curbside is available on iTunes or wherever you find your other favorite podcasts. Be sure to like us and subscribe. We want you to like us both because we're needy that way and because that will help other listeners like you find us. Check out our website, vcurb.com, for supporting materials, schedules, and other great stuff. The Virtual Curbside is an educational production of the Utah chapter of the American Academy of Pediatrics. The opinions expressed in this podcast, while carefully considered, are ultimately the opinions of the presenters and not necessarily of the American Academy of Pediatrics or our employers. And remember, the content of this podcast shouldn't be seen as a substitute for seeking actual personal medical care. If this is an emergency, hang up and dial 911. Otherwise, schedule a visit with a caring healthcare provider to try to get to the bottom of your concerns. None of this could happen without Elisa Stoddard, our extraordinary executive director of the Utah AAP. Many thanks to Tim Cosgrove for his help on the website and logo design. Production design and editing thanks to Phil Wirkus, who also composed the theme music. See you next time.